Okay, it's just gone 10, so I think we'll get started. Thank you again to everyone who's joined us. We've got a very good turnout, about 300 people so far and still going up, so that's great. And welcome to everyone who's watching us on Facebook Live as well. Just to note about asking questions, if you'd like to ask a question, please use the chat function, not the Q&A function. This will allow my colleague Nick, who's going to be monitoring the questions, to monitor them more easily. So please use the chat function if you can, and you might want to consider waiting until after we've done all the presentations before you ask your question, just in case we already covered the answers. And just to reiterate, this is a UK-focused webinar. It's designed for UK patients. Other patients are, of course, welcome, but just note that some of the recommendations and thoughts around the government guidance might not be relevant for you. So I just wanted to welcome our panelists. We've got Marc Auckland, who's the Chair of Trustees at CLL Support. Thank you for joining us, Marc. And we've also got Dr Piers Patten from King's College London. Thanks for joining us, Piers.
No problem. Thank you very much for inviting me.
So I'll be kicking off with a quick presentation that will cover some of the basics of shielding and various other topics of interest to CLL patients, as well as recapping our last webinar. So it's been about 3 weeks since our last webinar, so I think it's important to sort of recap the advice, and then Piers will give sort of an update as to anything that may have changed in the interim. So just as a reminder, back in the end of March, approximately the 16th of March, there was general government guidance put in place for those who are clinically extremely vulnerable to severe coronavirus, or COVID-19 to be specific. And included in this guidance was this statement here, which is all people with cancers of the blood and bone marrow, such as leukemia, so CLL included in that, who are at any stage of treatment. And the idea of this government guidance was to ensure that all people who may be extremely vulnerable were protecting themselves. As Piers will explain later, this is a new virus. It's impossible to know exactly who is at most risk and who is not at this stage, and it certainly wasn't sort of 6 weeks ago. So the government was taking a cautious approach when they put out this guidance. But what does this actually mean for CLL patients specifically? So this is the recap of our last webinar, which was conducted with Professor Chris Fagan, which you can still watch on YouTube if you're interested. And the guidance was that all CLL patients should be shielding on the basis that all CLL patients from the point of diagnosis are immunocompromised in some way. And obviously, this is important to note that, as I said, this is a previously unknown illness as well. So even though all CLL patients may not turn out to be as at risk as we thought, it's impossible to know immediately because this virus has only been around since December 2019. At the time of the last webinar, Chris stated that there was, at that point, little or no evidence of the effect of COVID on CLL patients specifically, and Piers will be able to give an update on that later. And at the time, Chris also recommended that you consider speaking to your haematology team if you have symptoms to sort of help you work out whether the symptoms you're experiencing are either COVID or whether they may be something related to your CLL. And I think that advice is still particularly pertinent. Now, will this shielding period continue? You may have heard some media reports this morning around potential announcements from the government about lifting lockdown. It's important to note that the initial 12 weeks of shielding doesn't end until June. And we just don't know at this point what the government is going to announce in terms of shielding. The media reports are relating to the general population and the general lockdown that's been put in place, whereas shielding was designed to be a further step for those who are extremely vulnerable. And as far as I'm aware, there's not been any particular announcements related to shielding as yet. Therefore, I think it's important that you try not to speculate or make a decision to come out of shielding too early. And if you're struggling with the shielding situation, we really urge you to reach out to Leukemia Care, to your haematology team, to CLL Support, and we will do our best to support you as much as we can. But it's important to note that at the time of giving this webinar, we are expecting further announcements on the lockdown and about and possibly about shielding. It's impossible to know yet. So keep an eye out for those. I just wanted to recap what shielding actually means. So shielding was sort of a new term that was devised to encompass the recommendations for those who are clinically extremely vulnerable. And the essential point is those who are extremely vulnerable should not be leaving the home. Now, a lot of questions have been asked about whether this includes exercise, and technically, according to the guidelines, those who are shielding, if they're following the most strictest guidance, should not be leaving the house for exercise, although that decision is also obviously one for individuals to make. The only exception in the guidance for leaving the home is to attend appointments, medical appointments. And Chris Fagan in our last webinar also expanded this to recommend that you should take care with items entering the home, as there's been some reports of COVID being present on items such as food packaging and boxes and that sort of thing. Shielding also has implications for those who live with you as well. And recommendations were initially put in place that those who live with those who are shielding should social distance themselves from the person who needs to shield. And this includes using shared spaces at different times, using separate dishes, cloths and towels, and staying 2 meters apart. Now, whether or not this is possible for individual households is something we have raised to the government when sort of questioning the shielding. And if you have any concerns about your ability to sort of maintain shielding within your household, please get in touch with either us at Leukemia Care or with CLL Support, and we'll try our best to provide advice to you on that. But what if I haven't received the letter? So you may remember that those who were advised to shield because they are clinically extremely vulnerable were sent letters and texts from the government. Unfortunately, this had some teething issues, which was quite understandable given the speed and the scale of the project. And we have been working behind the scenes, both us and CLL Support, to clarify the situation. It's important to note if you don't have a letter, you can still register for support, and it varies by region how you register for support, but local councils are a great place to start. Also, if you feel that you need the letter, say for explaining your circumstances to your employer, your haematology team and or your GP, depending on your local area, can still generate these letters even now. So it's important to keep pushing if you need that letter. And also please let us know, as again, we can help here at the charities. And the last thing I wanted to talk about very briefly was potential changes to treatment. Obviously, shielding has implications for medical care. If you're not able to leave the house, that's quite different to your usual situation for medical care. And Piers will talk about this in a little more detail later, but I just wanted to point out the general NHS approach to maintaining usual medical care at this time. So doctors are making risk-benefit analysis of every intervention. So what I mean by this is every time you are asked to leave the house, your doctors are considering whether that is necessary for you. And this is based on general guidance from NHS England and NICE, and it's important to note that if you urgently need treatment, that is still a priority. There has been no blanket guidance recommending that treatment should stop for cancer. I also wanted to ask everyone to be aware that you should not make changes to your treatment on your own, so do not stop taking any treatment you have. Do not switch to a different treatment if that's available to you or anything like that without consulting your clinical team. And please don't stop attending appointments without discussing this with your clinical team. As I said, they are making a decision as to whether every appointment you go to is necessary or not. And the final thing I wanted to mention is you may have seen a campaign from the NHS recently, I think it started last weekend, about just reminding the general public that the NHS is still open for business. If you are experiencing symptoms or have any concerns about any health issues at this time, please go to the doctor. I think the slogan for the NHS is "Help us to help you." GP surgeries and haematology clinics and everything are still open, and they're still here to help you. Please don't suffer in silence at home. So without further ado, I'll pass over to Piers, who will give a bit more detail from the clinical perspective as to the current situation for CLL patients and how we might expect this to change in the future. So, Piers.
Thanks very much for asking me to speak on this webinar. And clearly we are now several weeks into the epidemic, so we can try and, I was going to try and update you on a number of issues. I was going to add some more to Charlotte's words about shielding. I think an important area, and I hope I can reassure all of you that what we are doing in the hospitals and in primary care for management of CLL patients, and this is going to include all patients who are on so-called watchful waiting, those patients who might be about to start treatment and that might have been postponed, those patients who are already on treatment and what we're doing about that, and also what's happening in the clinical trial arena, because many of our patients are managed on clinical trials for CLL. I'd like to finish in the 10 minutes that I've been given just to talk briefly about what we know to date about COVID infection in patients with CLL. I think Charlotte's done an excellent overview of the current shielding advice from the government. As she said, these were brought in very rapidly, and they're being modified, I guess, or may be modified over time. In fact, the advice came in not that long before all the population was asked to effectively self-isolate and be at home and only travel for essential purposes. And I guess that will change in the next few weeks as we start to see a change in the whole so-called lockdown approach. My own view about shielding is it was brought in because there was a major concern that the disease groups and the type of patients who were identified by the government were likely to be at increased risk of COVID-19 complications if they were to develop the infection. But it's fair to say that we simply don't know, and we're still learning. I think in practical terms, I think the advice that is there is given for advice only, and you will need to interpret that as best you can. I do believe that it is sensible to follow this advice as closely as possible, and certainly when I'm in consultation with patients, I do point patients towards this recommendation and discuss with them how they may be managing to deal with the shielding advice. But clearly, you can interpret them as well as you can and work within that framework for what really works for you. And I personally feel that some of the things that are suggested are extremely difficult to achieve. But for those who've not been outside or been limiting at home, I would say that it is increasingly getting busy out there. People are around. If you live in a busy urban area, the park can be extremely busy. You can find people are running and jogging and coming much closer than perhaps would be advised. So although one wishes to open up as much as possible, I would just bear in mind that you might find that the environment out there is not quite what one expected, and to think about that should you wish to change your own shielding practice. The reason why CLL patients have been identified in that is that it is a diagnosis of a blood malignancy, and also that patients with CLL are known to have immune dysfunctions. And that includes those patients who are just on a watchful waiting strategy. And I know there's been some confusion about this, but to me, a patient is being actively managed if we introduce a watchful waiting strategy. So whilst there may not be any medications that are being used, you are being managed for your leukemia, and that would be included in the general shielding advice. I think this is a confusing point, but I think it's such an important point for us to think about. And certainly us as the treating clinicians have been working with the charities to try and clarify this point. I notice that people still say they haven't received a letter, and the actual process of that, it is from the primary care groups that this letter, the patients who were identified should have been generated. And I think we're continuing to work on that. I guess we are now reaching the end of this initial period, certainly for the lockdown for the general population, and it may become clearer over the next few days, the implications of that. But my understanding is that shielding advice was always meant to be in place until the end of June. And we will need to see how that develops over the next few weeks. So I guess we'll cut onto that in the question and answer session. I'd like to now move on to discussing about COVID-19 and its implications for the management of CLL. And I was just going to briefly touch on the 4 groups that I think are important. It's those patients who are on a watchful waiting strategy, those patients needing to start treatment, currently on treatment, and on clinical trials. In terms of watchful waiting, I noticed that someone was concerned, for instance, that they have an appointment coming up and should they proactively cancel that? I wouldn't advise that. I think that the clinical teams looking after patients are looking at lists and going through patients. I find that we have to do that on a weekly basis. I'm not being able to go weeks in advance. And that the clinic structure has massively changed over the recent weeks. We at King's College Hospital are performing in our CLL clinical service hardly any face-to-face consultations, but that doesn't mean that we're not having consultations with patients. We are doing this by telephone, we are ringing patients, and we are ensuring that all is well. My personal view about the usual things that happen in a clinic consultation, which clearly often includes a blood test, it's perfectly acceptable if on one visit, if I speak to a patient and things haven't changed much, there are no concerning symptoms, the patient is not complaining of losing weight or development of swellings in the neck, under the arm, or in the groin, or anything to make me concerned that that patient's CLL is progressing. Actually, I don't really need to have another blood count that day. I'm happy to postpone that for a few weeks. I think as we move further in and we continue a virtual consultation platform, which I think we will need to be able to offer at least, we are finding ways to get blood tests done at the local GP, done in the car park, done at the local hospital, as opposed to, for instance, I see patients who come from far away, and work on that. So that is the kind of things we're thinking of. But to have postponed perhaps a blood test on one occasion, in my mind, is completely acceptable, providing there are no symptoms of concern. And my view would be, if I rang a patient and discovered there were symptoms that would concern me, I would immediately act on that and would probably perform a face-to-face consultation, which would be done in a safe environment. Our own outpatient area, we now have patients having temperature taken, very few people are visiting. We are able to maintain as an appropriate socially distant environment. But the important thing is we don't have everybody coming in, that we actually speak first and then choose who we see, rather than our traditional, perhaps slightly chaotic clinic systems where everyone piled in. I think it's been a real eye-opener to all of us that we've been able to do this in such a short time. And I think we're learning quite a lot about that. Then we can come on to the point of those patients who perhaps were about to initiate treatment. And I often, in my own practice, this is often not a clear-cut time to when exactly to start treatment. And as Charlotte pointed out before, it's all about risk and benefit. And to me, the risks at the moment are still high in starting treatments, especially if I had to use a chemotherapy type regime in the current environment. And providing I'm happy to wait with a patient, I'd much rather supervise them closely, careful monitoring, and hold treatment at this time. That's not because I don't believe patients will ultimately need treatment, but sometimes it's often easy. Often you can wait for a few weeks, even a few months. And that's my experience and practice in CLL. And whilst all of us feel that this has been a very, very long period, we have to remember, actually, it's only been a few weeks so far. And although it seems like this has been around forever, it hasn't been. And actually, I think good consultation between your clinical team and yourselves to reassure you that we are carefully monitoring, I think is probably fine. I'm still reluctant to immediately start treatments today unless I think they're absolutely necessary, because I don't think it's clear what's going to happen with the end of the lockdown and where we are going to be with COVID-19. I actually think the hospitals at the moment are a safe environment, certainly in those areas which have been within the hematology clinic, because we know what to do now. We are practicing social distancing in those areas. But I'm not sure what's going to happen in the next 2-3 months. So I'm still being quite cautious about that. I think this is a very rapidly evolving situation and will change soon. The other issue I wanted to talk about was those patients who are on treatments. And some things that we did before have been changed. And this is particularly with those people who are on treatments with the newer therapies, such as ibrutinib or venetoclax, who might have also been receiving a monoclonal antibody. And in many of those occasions, we've actually dropped infusing the antibody on those patients. I personally would like to be able to deliver those later on in treatments, and I think that will be perfectly satisfactory. But also, many studies have done sometimes with and sometimes without the monoclonal antibody. And actually, we're making sure that you're getting the essential things that we think are most important for patients with CLL. And sometimes the benefit of receiving an additional treatment may only be marginal, which in normal times we think is sensible and what should be done. But in abnormal times, which these are, where the risks perhaps of coming to the hospital, receiving an infusion, it actually outweighs the potential benefit. So again, all of these decisions have been made not because with a rational basis. And I think I would advise everyone just to talk with their team about why they've chosen to do that. There are guidelines which are out on the CLL support, on the CLL UK forum. And I think these are completely in keeping with international consensus. And it is all consensus. This is what we believe to be the best thing, because there isn't an evidence base so far. There will be, we will get it, but at the moment there isn't. So that is why some treatments may have changed, and I'm happy if people have got specific questions about that to try and answer that. Finally, just talking about patients on clinical trials, again, we have learned that some of those can be altered or changed, or it's acceptable to have remote consultations as opposed to face-to-face ones. There are very strict rules usually about clinical trials. And again, one of the things I've noticed over the last period is that actually there's been flexibility there. And I think that's a good thing, because sometimes, again, it's all about risk benefit. And ultimately, even on, especially on a clinical trial, the patient's treatment and safety is the most important thing. And that's the way we've been operating. And that's why things may have changed. Previously, we might have said you had to do it in a certain way. And we've changed it because we think that's the safer thing to do. The final thing I thought I would talk about in this, I've probably been talking too long, so apologies for that, is what we know about getting COVID-19 and CLL. And I think this is a tricky area because we're still all learning. There's a lot of data collection going on. Each of us in our own individual practice have observed what's happening. I'm in constant communication with colleagues around the UK, and also internationally about what this means. And I think we will learn some things, but we have to remember that all the information we get is probably at the moment somewhat biased by what we happen to see. So for example, I'm a hospital doctor, and I'm currently looking after patients both in an inpatient and outpatient setting. So I have seen a number of patients with CLL who have been admitted to the hospital. Some of these patients have come in, and they've come in because they've had COVID-type symptoms and have done extremely well, and we've been able to discharge them. There are, unfortunately, other patients who may have needed to be admitted to the intensive care unit, and these patients are being managed in exactly the same way that all patients with COVID-19 are being managed in the UK. There has been perhaps some concern that patients with an underlying hematological malignancy, for instance, might be treated in a different way. And I will tell you that personally at our own hospital, this has not been the case. We have treated people weighing up the risks and benefits. And so if the patient has CLL, that has not been a reason why we haven't considered to offer all things available. And actually, one of the more interesting things that's happened is that some of the more experimental drugs that have been used for COVID-19 are actually available to patients with an underlying diagnosis of something such as CLL, and it's been possible to offer trials for them. So I think that's often having a diagnosis such as CLL will exclude you from a clinical trial. And interestingly, in the COVID-19 pandemic, that's not been the case. But I also know that from ringing patients from the clinic and ringing them at home, that they describe COVID type 19 symptoms to me, and they sound very similar to that which I'm aware of anyone in the general population having. There have been case reports written up of patients with COVID and CLL, which obviously are available now on the internet and things like that. And I think whilst those may suggest that the outcome might be different from other people without a diagnosis, I don't think any such conclusions can be drawn. And I feel that this is an important point. So, for example, there is a small series that has been written up from a UK hospital of patients with CLL who are described to have a poor outcome. But when you actually look at the detail of this, these are patients who are high risk of COVID-19 complications anyway. They are generally elderly. They've got other diagnoses such as high blood pressure or diabetes. And these patients we know do appear to be at higher risk of COVID-19 complications. So in my view, at the moment, we do not know if having a CLL diagnosis makes your outcome from getting COVID any better or worse than anyone else. But because we are concerned there's a risk that patients with CLL may have a tendency to do that, we do agree with the government advice that things such as shielding are sensible for patients with CLL. Anyway, I hope those are my thoughts on where we are in the pandemic at the moment. Very happy to answer any questions.
Thank you, Piers. That's very helpful. I think a lot of what you've said is reiterated a lot of what we said in our first webinar, but again, that's it's very important to sort of continue the messaging as nothing has yet changed, I feel. So I'd like to invite Marc to speak next. Marc, if you could just briefly contextualise some of what Piers has said, I guess, from your own experience and from obviously as chair of the trustees at CLL Support, what you feel the situation, how you feel the CLL community has adapted to the pandemic.
Sure, Charlotte, and I want to thank everyone who's calling in and all the members who've been supporting, asking questions, and particularly filling in the survey that's been going out jointly between Leukemia Care, CLL Forum and ourselves. That's really useful, rich information. I know Nick's leading the work to analyse the data, and we'll get back to you as soon as we can. We'll also put a communication out shortly after the government notice on whatever the step down general guidance is to say specifically what we would recommend for people with CLL. So what I said I would share is my experience of being shielded. I have CLL. I'm on the trial from Leeds. I'm on ibrutinib. I was last seen by the specialist just as the outbreak was happening. I got the letter on the 21st of March, so I've been in lockdown in my cell for 47 days. And I have been trying to keep to the shielding notice. And the point that Piers and Charlotte has made, and it's been made before, is these are recommendations, these guidelines. So when I speak to people on the helpline, I say, you are grown-ups. You've got to make your own decisions in there. These are the best advice to keep you as safe as possible, but it's your judgment call in the end. I've had people phoning up, and indeed I've done it as well. Where I live, I'm fortunate that I'm an early riser. I get up at 5 in the morning, and now it's getting daylight. I go for a walk, short walk when there's no one around, and come and sneak back, especially before my wife finds out I've been out. So my sort of day has gone into a routine, and that's the way I like to work. So typically my day is between 5 and 8. I will get up. Often I'll do a little bit of meditation or prayer. I'll go for a walk. And because it's quiet, that's the time I tend to deal with the flood of emails I get from members, from the CLL Support Trustees, good friends like Nick and Charlotte asking me to do things ASAP. And it keeps me busy up to about 8 o'clock when I'll have breakfast. During the day, I make sure things like I've got the soap or I've got gels there at the sink. I use them on a regular basis. The family know what the guidance is, so they'll prompt me if I forget, which I often do. I have a set of gloves by the front door. So if I'm the only one there, I can pick the post up carefully with it. I'll open it in the kitchen. I'll wash my hands again. And it gets into a routine. It becomes a way of working. You don't consciously need to think about it anymore. Then during the day, I'll make the calls to people like Nick and others there through the day till lunchtime. We have our main meal there, and I'll tend to do exercise in the afternoon. I'm lucky I've got a garden. It's spring. My wife and I like bedding plants, etc. So we'll be working out in the garden, getting some fresh air, keeps sane. The neighbours know my situation as well, so often they'll talk at a distance over the fence, asking if there's anything I want. In the early days, I'm sure like most of you, it was stressful. Understanding what does this mean? How long will it last? I've seen some of the questions coming in around, is it going to be 3 months? Is it going to be more? My view, it will be more. But again, you'll take a considered decision on what you do, how you step down. We'll try and help you. We'll send you guidance in there. In the early days, getting food, getting on the list were the challenges. Luckily, I got the letter. The local council phoned me up fairly quickly. I got the Red Cross parcel, as I call it, every Friday, using my gloves. Pick it up, open it, get the food out. It took a while to get onto the supermarket list because my name was on the vulnerable list, but it's my wife who's on the supermarket lists. And in one case, I had to photocopy my call, my letter confirming my CLL, the letter from the joint letter from CLL Support, the Forum and Leukemia Care, and I sent that to the CEO's office of Tesco. I don't expect you all to do it. I can see him getting a flood of letters, but he was very good. His office rang back and I got onto Tesco's shopping. So we got that. Piece of advice I was given by the council when they next phoned me up. I said, I want to give the parcel back. I want to come off that. And they said, don't come off the list. They had heard cases where people had gone on and said they don't need the parcel anymore and accidentally were taken off the vulnerable list. So what we do, we give it to the local church, the local food bank there, and it gets distributed in there. So routine is very important to me and to my family. I've got my grandson and granddaughter with my son and my daughter-in-law living with us. So they practice also the self-isolation and keeping clean, but I do give them cuddles. They're one of the big pleasures of life for me. The family is very important. My daughter gave birth a week ago, and the closest I've got is looking through the window of her home. I hope the police didn't see me, but looking through the window of the home, looking at the newborn there. And a judgment call, as much for the baby as me, as no, until I'm sure what the situation is on the disease for the newborn myself there, I will steer clear. So there's some downs as well as some ups in there. So the advice I like, and I heard a comedian say, is, stay safe, stay sane, and stay sanitized. Thank you, Charlotte.
Thank you, Mark. That's very, very useful to have some of the advice contextualized in terms of sort of a daily how you cope with things. I hope Nick doesn't mind if I just ask one question to Mark on what he said. It sounds as if you find routine particularly useful, sort of day to day. Would you advise your fellow patients to sort of try and set up a routine to help them cope with being inside more often?
Everyone's personality is different. I'm a bit of a workaholic, so the routine helps me to structure the day. Ex-engineer, maybe that's part of it as well. And luckily, the chairmanship and the collaborations with your good selves keeps me busy. But in that day, do make sure you've got time for rest and relaxation, whatever that looks like. On the Health Unlocked forum, we share stories of what hobbies we're learning, what interests we're taking up, sending pictures to each other. So make sure you've got time to relax. And with technology now, my daughter particularly sends me what the latest box set she says I should look at on Netflix. So we tend to watch that in early evening, because at the 5 o'clock morning start, I tend to be in bed with my cup of cocoa at 8, 9 o'clock in the evening, as people know.
Thank you for sharing that, Mark. Okay, so I think we'll move on to questions now. We've got 20 minutes or so. So Nick, I'd like to invite you to direct the first questions to whoever you feel is most appropriate to answer them. Just to let you know, you're on mute. There we go.
There we go. Thank you, Charlotte.
No
good morning, Piers, and good morning, Mark. very interesting story, Mark. It resonated very much with myself. And Piers, very extensive subjects that you've covered. We've got a rather large amount of questions, and I've been filtering through them. I think probably the one to start with would be the discussions that we've had with regards to the continuation of shielding and what that's likely to mean long term for patients. So I'm running through those questions first and having a look at this, you know, from a clinical perspective, Piers. We're shielding at the moment, and does shielding need to continue? And the longer it continues, will the benefits be worth it? It's quite a broad question. It's more.
Yeah, I mean,
how long do you think we are likely to be shielding? I know we're trying to guess the questions that are coming forward.
So I guess my view about shielding is that it's been in place since, I think, mid-March. So we're now at the beginning of May. And I do probably agree that it should continue for at least until the original period was said, until the end of June. My view is that I don't think any country knows what's going to happen when general lockdowns end. Most countries with bad epidemics have had that. It's difficult to interpret the data coming from China because it seems to have had pockets of infection as opposed to being more of a national picture. Whereas I think most European countries, it's been more generalized. I know areas of Italy were more badly affected than others, and that's also been true in the UK to an extent. And I think what we need to see is what the general rate of infection is once lockdown starts to ease, before we then move on to what we can do with shielding. Deeply frustrating, I can well appreciate. And it may be that people need to find measures which aren't quite as stringent as those in shielding, in the shielding advice. But once we're more confident that the rate of infection is low in general, I think then we should start to look at relaxing the shielding advice. So I think for the moment, it does have to stay in place. People do need to interpret the advice, you know, in their own way. It's you know, it is only advice, and I think that's important to make that point as well.
Thank you, Piers. Well, that summarises that nicely. On that same topic, a couple of questions have come in. Patients who've experienced COVID, or they feel they have experienced COVID. Does that make them immune to COVID? And as CLL patients, should they continue to shield?
Well, I think take CLL out of the equation. We don't know, unless you've been tested, whether one's had COVID or not. And we don't know whether one develops long-term immunity. One assumes you get short-term immunity. But I'm afraid we just have to look at our own government advisors to see that we don't really fully understand what becoming immune means. And until we have a better understanding of that, I think until we have serological tests, and what I'm talking about there is a blood test looking at antibody responses, it's very difficult to be able to say what our own immune situation is. Anecdotally, we all want to say, of course, now I've had it, I'm immune. And that may or may not be true for the general population, and even more difficult to know whether that's going to be the case for a CLL patient. There's a lot of questions there about live vaccinations. And what I will say about vaccination in general for patients with CLL is, although we advise non-live vaccinations, unless we often find that CLL patients don't respond in the way that we would expect and don't develop long-term immunity. So if we're going to use that principle to be the case when it comes to vaccination against other viruses, one might worry that that's going to be the case with COVID as well.
Oh, excellent, thank you. On that note, it's, you know, still around maybe the immune elements. I've got questions that have come in with regards to temperature. You know, are CLL patients likely to experience a temperature if they get a COVID infection?
I think patients are. I don't know if it's less or more likely. temperature is only one feature of this whole syndrome, and again, it's not universal. And in fact, many hospitalized patients have not particularly got a fever, particularly once you've developed the later complications of COVID. And actually, fever is not as big a feature later on in the disease as one might have expected. So the answer is, I do think that patients with CLL are perfectly capable of generating a fever, but they may not. And the same as the normal population. And whether that's more or less likely in CLL, I guess the data series that we're hoping to gather are trying to collect that kind of information, and we may know that in a few weeks.
I guess you already answered with a lot of your discussions about the unknowns. One of the questions along those lines was, Professor Fagan brought that up about, one of the third, potential outcomes or journeys that patients have who are diagnosed with COVID is the increased inflammatory reactions that cause the problems. And there were questions. One of the questions there is, could the CLL diagnosis or a CLL patient be ultimately protected because they might not mount that kind of response? So it was kind of aligned to the earlier question, but in a different way. I don't know if you've got any further comment on that.
The problem with COVID is not so much the initial infection, which is definitely an unpleasant viral type illness with fever, fatigue, lethargy, and cough being a prominent feature. It's this secondary inflammatory response, which is what we still don't really understand the underlying pathophysiology of that. And that appears to be an abnormal immune response. In fact, at that stage, you don't necessarily even detect virus. And one does speculate that CLL patients actually may not have that kind of aberrant immune response and therefore be protected. Anecdotally, a patient who I know of in my own hospital who went to the intensive care unit with a severe case of COVID lung, i.e. massive changes on their CT scan of changes and of concern. And I expressed a concern to the intensivist that this patient might do badly. And actually they came back and said, well, we were rather impressed how well they responded. And actually they've managed to be weaned off the ventilator rather better than other patients we've had. Okay. And so one doesn't know if the CLL was a contributing factor there at all, but maybe their inflammatory response was actually damped down, and this abnormal immune response actually was they didn't develop it in the same way. So again, I think the thing to say is that we all can find case stories, case histories, and things like that, but it's very difficult at this stage to be able to make any firm conclusion.
Excellent, thank you for that, Piers. I'm just going to, I was trying to group questions together, so I was sticking around the immunity related issues that said, one of those is a quarter of CLL patients might be receiving immunoglobulins either intravenously or subcutaneously. And I've got questions with, in that area that are concerned about continued access, those that receive intravenously, what's likely to happen? Are there negatives with having to stop? And are there, are people able to be switched over to subcutaneous and things of that nature? Have you got any thoughts in that area?
The patients can be switched over to subcutaneous, and I think you'd need to see what local practice is. We've been able to switch some patients over to subcutaneous. My view about IVIG is that in the initial pandemic here, it seemed to be more sensible to postpone an infusion or miss one infusion, because IVIG, although we give it once a month, does last longer than a month. And so there would still be some residual activity. And secondly, my feeling at that stage was that there was unlikely to be any anti-COVID activity in the IVIG because the population hasn't been exposed. Clearly, as the population gets more and more exposed, IVIG in the future would be expected to have anti-COVID antibodies. Whether that's a benefit or not, one doesn't know. But as we know, there are now trials of plasma in patients with severe COVID on the basis that having antibodies within that are going to be of benefit to patients. And until those trials report out, we won't know if that's the case or not. I think IVIG infusions probably should restart before too long, because the reason to give IVIG is to prevent those bacterial and other bacterial infections or other viral infections, which are common and still happen. And so it seemed to me that a pause in IVIG was sensible, because unlikely to give COVID risk. The greatest risk at that time was getting COVID, and one didn't want to be exposed to it in the hospital. Going forward, as hospitals learn how to manage COVID areas versus non-COVID areas, which is what is going on at the moment, then it will be safe to restart IVIG infusion. To just quickly touch on the what hospitals are looking at, hospitals are now going to be looking at COVID positive areas versus COVID negative, and keeping those very tightly apart, so we can safely deliver all those treatments that we need to do in a COVID-free environment. And once that's in place and working and operational, I think hospitals for those areas will be very safe with regards to COVID.
Thank you, Piers. And I don't know whether, just finishing off on the IVIG, because patients are self-isolating themselves as part of shielding and following strict hygiene, you would imagine also that there is less opportunity for contracting other infections with people following those regimens. So from a patient's feeling reassured point of view.
Absolutely, and it is interesting that when we do a viral swab for viruses in our service, we don't only look for COVID, we look for everything else. Yeah. The paraflu, the RSV, the influenza, and the adenovirus, and all those viruses are still there, but the incidence of them is down. Now that is probably because there's just much less community transmission of all viruses at the moment, because all the measures we're taking are good for not just COVID, but any infectious agent which transmits in the same way as COVID. The fact is that a society can't live being locked down, so we're going to have to work out a way of getting the balance right.
Absolutely. A couple of more questions for you, Piers, and then I've got a few to field to the advocates. I think it was just finishing off your questions with regards to, again, it's immunity related and it's to do with the research. Vaccinations, some of the questions have come, if they're coming available, do you know if they're live vaccines, and are the new vaccines suitable for CLL patients? Will they be able to have them? Are they worth having? And also, as vulnerable groups, would CLL patients be given priority access if they do come? Any thoughts?
So I'm probably not as expert on vaccines as I'd like to be, so I'm not entirely sure whether the Oxford group, for example, are trying to develop a live or conjugate vaccine. I think the same advice must fall, that if it's a live vaccine, that there would be a concern that could reactivate. And I think that's something we need to think about quite hard. In terms of do patients respond, the answer is it will have to be trial and error. And what I'm not sure about is with these vaccine protocols, whether there will be systematic testing for immunity. One assumes that would be an antibody test to make sure that you've developed antibodies to the vaccine for the general population in the trial design. But then there may be a concern that patients with CLL would be less likely to mount an appropriate immune response to vaccine, because that's what is the case for other vaccines. The argument, is it therefore useless and shouldn't be offered? I don't think it's true. I think we should offer it, but there may be a reduced chance of developing the appropriate immunity from the vaccine. But the most useful thing for a vaccine for CLL patients will be for everybody else to be vaccinated and not being exposed. And that's true for any infection. And the answer is that what you need is herd immunity out there. And as a group of individuals within the population, patients with CLL are lower. And what you want is everyone else around you to be vaccinated. And that's the key.
Thank you, Piers. And we will have experience with that with regards to the flu vaccine and ensuring those under our roofs are vaccinated to protect us. A couple of questions for advocates. I think we're going back to the question with regards to confusion over letters. What's been done to clear up the confusion over patients getting shielding letters within the CLL community. Obviously, from our own conversations with patients and our studies, we know significant groups aren't. So I think the first question really would be to maybe Charlotte and then Marc. What are we doing to get to the bottom of this and to help push for change?
I'll let Marc speak in terms of CLL specific activities. I know he's been sort of more heavily involved in those than I have, but in terms of generally across all leukemia types, there has been an issue with getting everyone who needs a letter. And as Piers has said, and I also mentioned at the beginning, it's important to recognise the scale of this activity and the speed that was needed, and quite frankly, the things that have been done that were imaginable several months ago in terms of technology and things like that. But at the same time, it's also important for us to try and raise awareness of the fact that some people have been missed. And I guess the activities we've been doing have included these webinars and spreading the message more widely. But also, of course, in the background, we're working extremely hard to sort of bring to the attention of NHS England that there is a significant proportion of people still missing these letters, and we're still working on that. And I just wanted to say briefly about what you should do if you don't have a letter yet is please get in touch if you are struggling to have that conversation with your healthcare professionals. There are things we can do, and I'll let Marc speak specifically on the CLL initiatives we've been working on with the haematologists to get the message out there.
Thank you, Charlotte. Yes, the biggest thing, the biggest success, I think, in the last few weeks has been the joint work and development of a letter from the CLL Forum, Leukemia Care, and ourselves on our respective websites, and has been sent out to members. And the feedback I'm getting through the helpline and emails from our members, and I think the same in Leukemia Care, is generally it's working. Once that gets in front of the GP or the employee or the specialist, at least it makes them think, it often makes them check. So we've had cases, I've heard from the chair of the CLL Forum, the chief clinician in charge there, that they've had conversations with clinicians all around the country. And in most cases, they've agreed and they've been moved to the list. Not every time. And as Charlotte says, if you haven't, do use our helpline, do send us an email, and we'll see what we can do to help. We keep pushing. I mean, this morning on the Today program, we had a piece on there about the issue around the gap, and it is around the language. So treatment for CLL is interpreted by a lot of members, by a lot of GPs, as only from, it doesn't include active monitoring. You know, it seems to be open to interpretation. So it'd be great if we could get that language changed. And as Charlotte says, we're lobbying as best we can, but the letter is the best point. If you're getting pushed back by your employer or GP, use the letter, use information, lobby your GP, lobby your specialist, be a pain in the butt. That's what I would say. That's what I do.
Yeah, I think I'd echo Marc's last point on that. This situation doesn't mean you can't still sort of have conversations and ask questions and challenge people. And if you've got concerns, please get in touch and we can help you do that, definitely.
Excellent. Thank you for those responses. And I think to note on that is that we're getting continual responses that people are continuing to receive their letters. Just finishing off on that, any special advice with regards to discussions with employers? This is something that's likely to raise its head again now, with obviously some changes apparently likely to happen for general potential near future easing of some of the restrictions, and people expected to be back at work. If there are quite a few people are still having challenges with employers because they haven't had the letter, are there any other routes patients should take? Charlotte?
Yes, we can assist with that as well. So the first thing we'd always say is to, as per what we and Marc have just said, is to try and get hold of your letter, because that is the most sort of authoritative information that your employer will recognise the NHS as as official body and the government as official body, and it'd be the easiest way for you to have that conversation. But appreciate that hasn't been possible for everyone, so we have also been assisting people by sending out letters, and both the CLL Forum's letter, but also letters written from us to explain the government guidance. And I think it's not that the majority of employers aren't specifically doing this out of malice. It's more a lack of understanding, particularly about blood cancers. I think blood cancers aren't very well understood in general by the general public. So sometimes it is just a case of a little nudge from a charity like ourselves to explain the situation, explain what a blood cancer is. It helps. So please get in touch with either us, or I'm sure Marc and the CLL support team would be more than happy to assist with a similar thing as well.
Just if I can add to that, Charlotte, I fully support. The other thing, I'm hoping longer term, there is a review on the way we work. So maybe there'll be more home working, distance working, etc., to help alleviate some of the issues in the environment that brings us into close contact. I think over the last few weeks, there's been a major revelation in companies that I've talked to about when they do need people working in an office and when they can work perfectly adequately from home. So I'm not looking for nirvana there, but I think there will be reviews from companies as to the way they work in the future.
Thank you, Marc. So just maybe not drawing a line, but just rounding up there, we've had a lot of letters of people unsure about whether they should be receiving letters because they've been post-treatment for some years, or they've been in watch and wait for a lot of time. I think the consensus that's coming out of this is everybody in CLL should be shielding. How that's interpreted is what has been open to discussion here. And that led me into one of the questions that I have is, can I go out to exercise if I am shielding? How I know we touched on that earlier, but have you any more thoughts in this area about who is covered in shielding? That is everybody. Those who are watch and wait, have been watch and wait for a long time, and those that are post-treatment after 2 years, if they haven't received a letter and they need access to the support, then they should be seeking to contact us, the charities, clinical community, registering online. Any other comments in that area?
No, I think you've encapsulated the advice right well. The exercise issue is a difficult one because I appreciate it is difficult to be trapped in all day, every day. And from Leukemia Care's point of view, we say this is the advice. The general advice is that you shouldn't be going out to exercise, especially if you live in an urban area where there's lots of people around. And Piers has pointed out that there are a lot more people around at the moment. It's getting busier out there. People are, I live in the centre of London and it's definitely getting busier. But at the same time, if you want to make a decision for yourself, I'd encourage you to do it with your clinical team and sort of balance the risk for yourself. Sorry, Piers, you go ahead.
Well, I think my advice about that is are you confident that when you go out and exercise that you are going to be able to maintain an appropriate, and for the sake of argument, 2 metre social distance? And I say 2 metres because that's current government advice, but it is different from other advice throughout the world. And we understand that may change. Clearly, if you're in an area where there are perhaps open fields and you're never going to come across anybody at all, that's going to be very different from living in a central London location, for example, where the park has been as full as I've ever, I've never seen them quite so full as now. And Marc, you're going to say something?
Yeah, we haven't really covered it here, but certainly I speak from personal experience. The longer the shielding goes on, the harder the emotional and mental stress comes. So there is a balance in there. As Piers says, it's recommendations, it's a judgment call. So if it means for your own sanity, even sitting on your porch and chatting to a neighbour over the fence, or getting up early morning or going out for midnight walks, I've heard, so you avoid the contact. If that helps you mentally and emotionally, personally, I'd say that's okay. But as Piers says, making sure you can keep as safe as possible.
And in terms, I think Chris Fagan brought this up at the first one, and I will say I've had personal experience of this because I have an elderly relative who is shielding. There are ways of working out. I was able to go and celebrate my father's 80th birthday by providing entertainment for him with my family in I felt an entirely appropriate way. But it did require a visit from myself. Maybe I shouldn't be on camera for saying this. I'll get to at least the location of his house, but I didn't cross the threshold of it. But we were able to socially interact in a distant way, which was a bit different from Zoom, but it was not one where I felt there was any infection risk at all. There are ways and means.
Thank you, everybody. I think we're just getting pretty close to coming to the time then. I've just got a couple of questions around treatment. And, you know, one of the things is everybody's now experiencing more digital engagement with their patients. And Mark raised this about changing practice for the future. From a clinical point of view, is this something that's likely now going to initiate some change that has been talked about for some time? And the other question I've got was around the clinical trials. Is obviously clinical trials at the moment are maybe some are on hold, people due to start. When do we anticipate the clinical trial structure to restart again as was planned? Any answers there? Any comments, Piers?
So I think there are two issues with clinical trials. There's the ongoing ones and those ones which were about to start. The ongoing trials haven't stopped in terms of all patients are still receiving treatment if clinically appropriate, but there were ways of bringing in delays and changing things. For instance, those patients perhaps on the FLAIR study who were going to receive venetoclax as a ramp up, we've just held doing that, and we will reintroduce that when we feel it's safe to do that. Going back to my point, I think going on to a clinical trial, which are the ones which are still open, are still available, is a judgment by your clinician whether starting treatment now is the right thing for you. And I go back to my original point. So whether it's a clinical trial or not, it's not that the trials have all suddenly stopped. It's just that the numbers going into them have significantly reduced. Once I can see a clearer point in the next, I'm hoping in the next 1 to 2 months of where this is going, I'll be more confident about putting someone to start to start new treatment regardless of trial. New trials which require authorization from the various regulatory bodies are still mainly on hold because priority is being given to COVID-19 research. And I guess that's a more general point, which I can't give a timeline on, and that will be more for those regulatory bodies to decide when they're going to be able to open up to more than just COVID research.
Thank you, Piers. I've got one last question. I've got to apologise to everybody. I've never seen so many questions and we just can't cover them in the time, but I'm sure that as a panel and as charities, we will collate these and respond. One that I find personally quite relevant, as looking at the survey, we will soon be releasing survey results next week in a summary. We've got to, just to explain the surveys we've been running, we've had phenomenal participation. You know, coming close to 2,000 people have participated over the 2 surveys, which has given us some great information. But one thing that has come to mind that's shown is that how many people are not living alone. There's a significant group that are living alone, and we've got to, and obviously we've been discussing that about how to get support letters and everything. But one of the big challenges is those that are not living alone, where they're living with people who are worried perhaps that they, now lockdown is to be lifted, will be more in circulation, and concerned about the risks that they're likely to put their partners or family under. So I'm just wondering if, as a group, because this is something that is imminently about to change, to end things on here, just to share where CLL patients will still be shielding, the occupants of their households no longer will have to isolate. Where do we go from here with that? And any suggestions how people can maintain, their own risk analysis and protection? Any thoughts? Charlotte, Mark? Yeah.
It's important. From my perspective, I think it's impossible to say at this point what the advice will be, but it is definitely an issue that needs looking at. And we've already seen this issue actually in part with people who have CLL who happen to live with key workers. I mean, being a key worker and living with someone with a long-term illness are not two things that are mutually exclusive. And I think that's one area of advice that has been somewhat lacking so far. But I'm sorry, I don't think I've got any ideas on where we can go from the future. Maybe Mark's got something he'd like to share.
There's 6 of us in our house. My son is a CAD designer and is a key worker doing the packaging for samples, etc., in the pharmaceutical and medical industry. So he works long hours there getting the packaging and things designed. So he's in and out. So he's aware of the situation as well. So we take as much care as possible in the shielding. So he's got the dining room. He's turned that into an office. He goes in and out there. He goes to work when he needs to, which is maybe once a week in there to look at the design of the packaging, etc. When he comes back, the first thing he does is a shower, washing hands. I tend to keep out the way that day when he comes back. We're lucky enough, it's a big enough house we can do that. And I'll see him in the morning. And it seems to have worked so far. The children, my grandchildren are 6 and 2. It's very difficult to explain to them the situation, but they tend to spend most of the time in the garden. They do go for walks, but the mum and dad try and keep them separate as well. We've started talking about when it goes back to work. I think for the first, until I get advice separately, we've said I will try and keep separate. So I've got my study, I've got my own bedroom and bathroom there, and try and keep a bit of distance until we see how things settle down, and obviously keep the hygiene regime going. That's all I can say at the moment.
Any parting shots as Piers that you may advise your own patients, or a question? Any thoughts?
I think what Marc says is extremely sensible, and I think that those people who are sharing a household with someone who is coming and going, providing that person coming and going is following hygiene rules as well as they should be, and I think that is all that is needed. And then clearly you've got to have some kind of social interaction, but it will have to be in some kind of distant format, which may be more difficult in some households than others, of course. I mean, Marc sounds like he's got a big enough house for that, but not everyone is as fortunate as that.
Well,
okay.
I think that brings things to a conclusion at the point. And again, apologies, we have a large amount of questions. I'll hand back to Charlotte, and thank you everybody for attending and allowing me to offer your questions, and fantastic information from everybody. Cheers.
Thank you, Nick, for fielding those questions for me. Not an easy job. So we just wanted to end on sharing the support that's available from both Leukemia Care and CLL Support. Marc, did you want to just briefly chat to this slide about what CLL Support can offer at this time?
Yeah, sure, Charlotte. Yeah, so as you can see on the side, it's free. We're keeping the information on the news section of the website up to date. We're sending out e-bulletins to members every 6 weeks. So feel free to join. If you're not getting it, sign up and we'll make sure you get the latest information, latest updates, latest guidance on there. The regular meetings we've had to suspend, as many of you will be aware, but what we're doing for this period is we've joined forces with our good friends Leukemia Care and doing these web conferences in there. There's still the helpline, feel free to phone. The danger is you might get me, but sometimes you can get a useful person answer as well. So use the website, use the forum. I found the forum really good. There's some great people, great advice, and great conversations in there if you can't get out. Thank you, Charlotte.
Thank you, Marc. And I guess it's the same message from us here at Leukemia Care. We're doing what we can to put information out there, regular newsletters, far more regular than we've ever done before, webinars, and of course we're working with charities and other charities like CLL Support in the case of CLL as much as we can to ensure the messages are aligned and get the messages out there as much as possible. And our helpline number and email address are on the bottom of that slide that you can refer to in the recordings later. Of course, other sources of support are available, such as Blood Cancer UK and Lymphoma Action 2. And I guess it just remains for me to say thank you. Thank you to our panelists, Piers, Marc and Nick, for fielding the questions. Thank you for your time, much appreciated, especially Piers. I know I'm sure you're very busy at the moment. I will be saving the chat, but please, if you feel like we haven't answered your questions, do get in touch with either me here at Leukemia Care or with Marc at CLL Support, and we'll do our best to help you. Thank you, everyone, and see you next time.
Bye. Bye.
Thank you.